Can you share the slides now?
3, 2, 1. We are live now, ma'am.
मेरे में
बच्चा फेस चला गया रेड रेड का बच्चा
Red, unmute, red बच्चा unmute, muted, muted.
Listen,
Hello.
sir, shall we start?
yes please.
Oh, good evening, friends. A warm welcome to the 59th episode of Secret of Neurology, the knowledge feast for all the neurologists and the other doctors. This platform brings together young mind, experienced neurologists, and the rare case for the deep learning and discussion. This evening session is brought to you in collaboration with AAP, Vishwanathan Government Medical College, Tirchi, and we extend our sincere thanks to the team for making this possible. Today's topic for is very interesting, an interesting case of recurrent visual loss, a case that promises to challenge our thinking and spark engaging the discussion. It is an honor and privilege to introduce the two stalwarts or pillar of Secret of Neurology, our respected course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir. Dr. Sudhir Shah sir is the professor and head of neurology at NHL, MMC, SVP, IMSR, Ahmedabad, and director of neurosciences at Sterling Hospital, Ahmedabad. A prolific author with 6 books and numerous national and international journal contributions. He has received many prestigious awards, including the prime and the most prestigious Padam Shri Award in 2016 and the Bharat Gaurav Award at the Senate of France in 2024. And beyond this, his medical expertise, that is in stroke, epilepsy, and neurodegenerative disease. Dr. Shah is globally recognized for his research on prolonged fasting and which is featured on the platform like BBC and Discovery Channel also. Further to this, our second stalwart post-rector, Dr. Lakshmi Narasimhan sir, is the professor and head of neurology at Shri Ramchandra Institute of Higher Education and Research, Chennai. He is renowned worldwide eminent personality for his contribution to the neurology education. Sir has received A.B. Baker Award for Best Global Teacher from American Academy of Neurology and multiple international awards, including which includes the Elsewhere Atlas Award, a long-standing part of the World Federation of Neurology. Dr. Narasimhan is also the visionary behind the Shine, a highly successful that is a national level training program for DM students across India. We are truly grateful to our both the course director for their unwavering dedication and continuous mentorship, which has shaped the secret of neurology into the most followed neurology teaching platform in India. With that, I now invite Dr. Sudhir Shah sir to take over the session and introduce today's panelist and begin the session. Over to you, sir.
Thank you, Mr. Shraddha. First of all, I would like to give a warm welcome to all the uh, delegates who have been continuously supporting this wonderful webinar series by their attendance and making this a great success story. This is, as has been told, 59th consecutive monthly episode, which itself is a record as far as our country is concerned. And every month, month after month, we have been able to get the best of the institution, best of the teachers, and best of the cases for the presentation and discussion. So this time we have KP Vishwanathan Government Medical College Trichy and Professor V. Ravi Kumar would be heading the concluding remarks, while Dr. Ashwinji, the senior resident, would present the case, and Dr. Jenu will, assistant professor, will do relevant case discussion. The case is about interesting case of recurrent visual loss. Now, before I introduce the speakers, it's my humble duty and rather my privilege to thank and acknowledge all the previous institution and speakers who have contributed profoundly for this wonderful webinar conference. And as you are all aware, that this is one of the most sought after series, and many MD, DM students, they continuously listen to this. They 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 learn from this how to present the case in the best possible way and how to dissect, discuss, and then to take it forward. So this is one of the best learning sessions. That is why it has been so much appreciated, not only India, but across the globe, because so many countries have participated in our program as a delegate. Now, I'm very thankful to my colleague and my co-course director, Dr. R. Lakshmi Narasimhan, who needs a large applause because his tireless efforts has made this journey very, very successful and up to the mark. So thanks to you, Dr. Lakshmi.
Thank you, sir.
And I'm also here to thank Mr. Arun Chadda and team, the Celestial Division of INTAS, the Global Cell and all that. That is, thank you, Mr. Chadda. And I must also, on a lighter tone, uh, say that by now 59 episodes, you have all listened them carefully. So now you should be honored with the honorary PhD degree of neurology. Thank you for all the logistic support, you and your team. Now let me introduce the speakers. The first and the foremost, Dr. Ashwinji, the senior resident from same Department of Neurology of CAP Vishwanathan Medical College, Government Medical College, that is from Trichy. He is going to present the case. Second, Dr. Jenu Santosh is the Assistant Professor, Department of Neurology from the same institute, Trichy, is going to discuss the case in details and localize and give differential diagnosis. And then, may I have the next slide, please? Dr. V. Ravi Kumar, Professor and HOD, Department of Neurology from the institute, will give his final remarks, concluding remarks, and golden pulse for all of us to learn and remember. Now, Dr. Ravi Kumar has 8 national and 6 international publications. He is a member of Academy of Neurology. His area of specialty is stroke. And in a very short notice, I've been told he has taken up this responsibility of sharing knowledge from this wonderful platform. Once again, I thank all of you, and over to Professor Lakshmi for a few words, please.
So there are quite a lot of unsung heroes in the country who are highly talented, but they never have an opportunity to come to the limelight. Ravi and Dr. Professor Ravi and Professor Rajshekhar, there are two of them. Two of them have, to my assessment, they have great knowledge and trained quite a lot of students across the various medical colleges in and around Trichy. And in fact, Professor Ravi Kumar has served in Chengalpat Medical College, then moved on to Tanjore Medical College, and then subsequently near the superannuation, he got superannuated from Trichy Medical College. In fact, I attended the function for his superannuation. I could see the affection shown by his former postgraduate students on the occasion of his superannuation, which speaks volumes about his teaching caliber. Thank you so much for joining us, Dr. Ravi. And over to you. Kindly take over the proceedings. Thank you.
Thank you.
Thank you, Lakshmi, for very nice introduction. Now, Dr. Ashwin can present the case now.
Ask question to person. Yes, go ahead.
Yeah.
Yes. Yes, thank you, sir. Good evening, respected
perfect.
professors. Good evening, everyone. Now I would like to carry a case of recurrent visual loss. The case history is as follows. A patient presented with recurrent episodes of defective vision of one eye followed by the other eye since last 1.5 years. So we'll be discussing, there are altogether 5 episodes. We'll be discussing each episode wise. So first episode started 1.5 years back where she developed fogginess of vision of her right eye associated with pain on moving right eye, which was acute onset and worsened over 3 days in the form of difficulty in identifying distant objects followed by near objects associated with difficulty in appreciating colors in her right eye. She was admitted for the same in a private hospital. Actually, she came to us after her during her 3rd episode. During the first 2 episodes, she was admitted in a private hospital. So we took the details from discharge summary. She was admitted for the same in a private hospital, and IV methylprednisolone injections were given for 5 days. Her vision drastically improved in 3 days, and she was discharged home after 10 days. The time of discharge, her visual acuity as well as color vision on right eye improved. The second episode, patient developed similar complaints of fogginess of vision with pain on eye movements and sudden flashes of lights in her left eye. Initially, it was right eye, now in the left eye, 1.5 months following the first episode, for which she was admitted again in the same private hospital. She was again administered 5 days of methylprednisolone injection, and her vision improved by 3rd day, and by 5 days she got completely improved. At the time of her discharge, her visual acuity and color vision was almost improved. Third episode occurred 4 months
Ashwin.
following the
Dr.
complete
Ashwin.
recovery from the.
Dr. Ashwin, hello, Dr. Ashwin.
I'm sorry to
There's a lot of
interrupt.
echo.
There is a echo. I think there are 2 simultaneous devices that are operated. Can you stop one of them?
One
Ravi,
second,
sir,
sir.
do you mind if you can mute your one? I think.
Yes, madam. Okay.
Yeah, sir, you can continue now.
Ma'am, now it's okay, ma'am?
Yeah, it's fine now.
Okay. Should I repeat or shall I continue?
No, again, it is there is a echo in your voice.
Can you repeat the
Echoing,
previous
ma'am?
slides?
Yeah, you can start, please. Then only we'll be able to understand.
Okay, ma'am. So the first episode, it started apparently 1.5 years back. So
Yeah,
the
it's
initial
fine now.
first, it's fine. Ma'am. Okay, ma'am. Fine. So initial first 2 episodes, she was treated in an outside hospital. So 3rd episode, she came to us. So we could retrieve the data of the first initial 2 episodes from the discharge summary of the previous hospital, ma'am. sir. So the first episode is as follows. She was apparently normal. 1.5 years back, she developed fogginess of vision in her right eye with pain on moving the right eye, which was acute onset and worsened over 3 days. The form of difficulty in identifying distant objects followed by near objects associated with difficulty in appreciating colors in her right eye. She had color desaturation. Then she was admitted for the same in outside the hospital. She was given IV methylprednisolone injections for 5 days. Her vision drastically improved in 3 days and she was discharged home after 10 days. At the time of discharge, her visual acuity and color vision on the right eye was improved. Second episode started 1.5 months following the first episode, where she had developed pain and similar fogginess of vision in her left eye. Initially, it was right eye, now on the left eye, with sudden flashes of lights in her left eye, for which she was admitted again. And she was again administered methylpred injection, and her vision started improving by 3 to 5 days, and she got completely improved. Third episode started 4 months following the complete recovery from second episode. She got this is the first time she came to our hospital. She got admitted in our hospital with similar complaints of defective vision of her right eye, this time again right eye, associated with pain on eye movements and right-sided unilateral dull-liking type of headache over the right temporal region. She was given IV methylpred, again we have given her IV methylpred, and after 5 days, she was started on oral prednisolone and azathioprine. Time of discharge, her visual acuity and color vision improved. After 10 days, she developed severe allergic reaction to azathioprine in the form of reddish spots throughout the body associated with edema. Immediately, the offending drug was stopped and she was told to continue prednisolone tablet. She was under regular follow-up and the medication was tapered and stopped over a period of 6 months as she was planning for pregnancy. The fourth episode, it happened 2 months after stopping the prednisolone tablet. She developed similar episodes of defective vision in her left eye. She was again started on methylpred pulse therapy and was discharged with oral prednisolone. Her vision improved in 3 weeks' time. This is the fifth episode, that's the current episode. She stopped steroids as she was pregnant. 2 months following withdrawal of steroids, she developed defective vision in her right eye again, associated with pain on right eye movements in the form of blackened spots in the center of her vision, followed by slow expansion of the spots. She had difficulty in identifying colors. By 3 days, she couldn't perceive things at the center of her vision. She couldn't identify faces in front of her with history of flashes of light on eye movements associated with redness and watering from the right eye. Within a week time, patient developed similar complaints in the left eye associated with photophobia, redness, watering of the both eyes. There is no history of objects appearing smaller or bigger in size. There is no history of macropsia, micropsia, no history of any distal option metamorphosia, and no history of any difficulty in seeing surrounding objects, no history of any floaters or any halo or any visual obscurations, which is worsening on coughing or straining, no history of any feeling of curtain falling over the eyes, no history of recurrent vomiting or any severe headache not precipitated by postural change or Valsalva, no history of worsening of vision on looking to either side. There is no history suggestive of involvement of other cranial nerves or higher mental functions, motor, sensory, cerebellar, autonomic, or systemic involvement. Past history, personal history as well as family history were not significant. Summarizing, 26-year-old female patient with no prior comorbidities presented with recurrent episodes of painful defective vision alternating between both eyes, with last episode presenting with redness and watering, photophobia, painful defective vision of both eyes without other cranial nerves, motor, sensory, autonomic, cerebellar, higher mental functions, or other systemic involvement. These are the timeline of events. First episode with right eye involvement, painful vision. Second episode with left eye, painful defective vision. Third episode again right eye. Fourth episode again left eye, painful defective vision. Fifth episode with the bilateral sequential involvement of both eyes with painful defective vision with redness, photophobia, and watering from the eyes. So localize. First episode, I would like to localize in the right optic nerve. Second, to the left optic nerve. Third and fourth, to the corresponding optic nerves. Fifth episode, I would like localize with both optic nerves with bilateral uveitis.
Shall I present my slide, sir?
Yeah.
Shall I stop sharing, sir?
Hey, you present that.
Yes.
You continue to present.
Sir, we have put a slide in a way that after the history, I'll just localize few things, and after that, he'll go to the.
So it's your convenience. Whichever way you are comfortable.
Okay, sir. Dr. Ashwin? Oh. So am I visible?
Yes, yes.
Yes, thank you, sir. Thank you for giving the opportunity, sir. So I'll just localize the history. So as Dr. Ashwin told, the patient was normal till 1.5 years back, and he presented with just a fogginess of vision and right eye, as well as pain on moving the right eye, which was acute in onset. Also, the next complaint which was told by the patient is there was difficulty in appreciating colors in her right eye. So this is just a unilateral vision loss, so which we localize to the anterior visual pathway. So that could be either a choroid or a retinal pigment epithelium, a retina, an optic disc, or an optic nerve. So coming on to whether it is a retina or optic nerve. So retinal symptoms are usually flashes of light. They can present with photopsia, micropsia, macropsia, or metamorphosia. The optic nerve symptoms are a fogginess of vision, color desaturation, and painful vision loss. And sometimes patient can have flashes of light. And among retina, the center part is the macula, which we call. So in macular involvement, we'll get a central vision loss as well as distorted vision, and the rest of the retina will have peripheral vision loss, flashes, as well as floaters. So after methylprednisolone, the patient's vision gradually improved and she was discharged. So based on this history, I would like to localize this lesion to the anterior
Santosh,
visual.
Jenu,
Sir?
what was the Amsler's grid finding?
Sir, there was enlarged blind spot was there, sir. Hello, sir?
Amsler's grid, was there any distortion of the lines?
No, sir. No, sir. No, sir.
Okay, thank you.
No, sir. Thank you, sir.
Continue.
The site lesion at the present during this first, thank you, sir. In the present episode, it is an anterior visual pathway and it's an optic nerve. And coming on to the second episode, it's in the left eye. So the patient had the similar complaints of fogginess of vision associated with pain, also flashes of light, and the same localization is the same since it is a uniocular vision loss. It localizes to the anterior visual pathway, that is left optic nerve. And flashes of light, it can come either in the retina or there's no optic nerve too. And third episode, it's in the right eye. The patient had similar complaints like defective vision associated with painful eye movements. Also, this time patient had a mild dull aching type of headache over the temporal region. So localization is again the visual impairment associated with pain localizes to the optic nerve on the right side. And the cause of pain, the site of pain in the optic nerve lesion, usually it's behind and around the eye, and it is triggered by eye movements because optic nerve is connected to the extraocular muscles. And fourth episode, again in the left eye, patient had, after stopping the prednisolone, patient developed symptoms, the same similar complaints like vision, fogginess of vision, as well as defective vision. And the fifth episode, so this time patient developed symptoms in both the eye. Initially started in the right eye, followed by the left eye. This time she had few more symptoms were there apart from the defective vision. The patient had blackened spots in the center of vision. Also, patient also had difficulty in identifying the colors. Also, patient had flashes of light associated with redness and watering from the right eye. So I've highlighted those things. What are the new things patient had? The redness and watering from the right eye. So initially it started in the right eye, as then it progressed to the left eye. So localization of this lesion is optic nerve as well as in uvea, because the patient had redness and watering and vision impairment, which is unlikely. Redness and watering are unlikely seen in optic nerve lesions. So this time we localize it to the optic nerve as well as to the uvea. So this slides, Dr. Ashwin has already highlighted the timeline of events. So first 4 episodes localized to the optic nerve, and the 5th episode localizes to optic nerve as well as to the uvea. So the structures at the end of history, or either recurrent optic nerve involvement in alternate eyes as well as uvea involvement, and it is a recurrent optic nerve neuritis with bilateral uveitis without higher mental function, motor, sensory, cerebellar, or autonomic involvement. So at the end of the history, we thought of a possibility of, so if it is only an optic neuritis, the possibilities we thought of are NMOSD spectrum disorders, MOGOD, it can be a multiple sclerosis, since a young female, autoimmune disorders, like SLE, sarcoid, Behçet, and infections like TB, syphilis, and Lyme's, and a crayon we thought of. And adding up the uveitis, we had few more differentials like multiple sclerosis, as already told, VKH syndrome, Mohod, and infections like syphilis and herpes. So at the end of our history, these were the
Expand.
possible differentials.
VKH is Oak Koyanagi Harada. Just expand that for
Yes.
the sake of viewers.
Yes, thank you, sir. So at the end of the history, these were the differentials we had in mind, and I asked Dr. Ashwin to proceed on to the investigations.
Yes, sir. Yes, sir. The examination and investigation are as follows. This is the first episode where she developed difficulty, painful visual loss of the right eye. That time her visual acuity at admission was 1/60. At discharge of 10 days, it became 6/9. Color vision was defective. At discharge, it improved. Field of vision, she had central scotoma. Pupil, RAPD was present. Fundus, media was clear. Disc hyperemic and edematous with blurred margins, and vessels were obscured at the disc margins. Left eye was normal. Other cranial nerves and spinal motor system were normal. So this is the second episode where she developed a painful visual loss of the left eye, where she had on admission, she had visual acuity of 2/60. Discharge, it again improved to 6/9. Color vision was defective, which improved after discharge. Field of vision, she had central scrotum of the left eye with RAPD was present in the left eye. Fundus had a similar picture like the previous episode. Hyperemic disc with blurred margins and vessels are obscured at the disc margins. Here, this time, right eye was normal, and other systems were other cranial nerves and other systems were normal. Third episode, again the right eye involvement. Visual acuity was 1/2/60. Discharge, at discharge, it improved to 6/12. And similar color vision was defective with a relative often pupillary defect of the right eye with a hyperemic fundus, and other systems were normal. So during third time, we did a routine blood investigations were done. CBC, RFT, LFT routine investigations were all normal. We did a CSF analysis. CSF protein showed 26 milligram per deciliter when sugar of 64, and cell count of 2 cells, and CSF oligoclonal bands were negative. We did a serum aquaporin 4 and serum MOC, which both turned out to be negative. Then we did an MRI brain with optic nerve cuts, which was normal. With contrast, and it was normal. There were no hyperdensities over the optic nerve. And ANA profile was done, it was negative. PNCA, CNCA were done, it was negative. And VEP showed prolongation of P100 in the right eye. This is the VEP picture showing a prolongation of P100 in the right eye. And after that, again, the fourth episode, when she arrived, her visual acuity was 2/60. Discharge, it again improved to 6/9. And her color vision was defective, and again improved. It again improved during the discharge. And the same similar picture of pupils with RAPD, and similar picture of fundus, like similar episodes. And here we can see left eye. This is the fourth episode, left eye, blood margins, and the right eye. Here, we can see the disc hyperemia as well as the blurred disc margins. And that time OCT was done. OCT of the right eye was done, and left eye was done. Here, left eye, we can see the macula, the disc edema was there. So the OCT, all superior, inferior, nasal as well temporal quadrants were white. There was an edema. We can see marked edema on all 4 quadrants. In the right, it was resolving. So we could see edema on the superior, nasal, inferior quadrants, but temporal quadrant, the edema almost subsided. And here again, we have done routine investigations, and we did a CSF. We repeated a CSF analysis. We again sent for CSF OCBs. They were all turned out to be negative. The repeated serum MOC and aquaporin 4, they turned out to be negative. Repeat MRI brain with optic nerve cuts with contrast was done, and it was normal. And this time we did serum AC levels turned out to be normal, and CT test was done, it turned out to be normal. And VP prolongation was there in the left eye. Here we can see the left eye, right eye it improved, and right eye it is improved, and left eye we can see a VP prolongation of PRN is prolonged in the left eye. These are the pictures of MRI pictures with contrast showing no enhancement, no nerve enhancement. And we did a screening of the cervical spine, whole spine screening also. Whether there was no T2 hypertension lesions were not there. No features of LETM was not there. And even the optic nerve size, thickness, everything was normal. Contrast, there was no abnormal enhancement was not noted. So this is the fifth episode. Fifth episode, in the right patient had chemosis and redness and watering of the right eye, followed by left eye. After 1 week, she developed in the left eye also similar complaints, and RAPD was present in the left eye, and visual acuity was 1/60. After 5 weeks, improved to 6/24. It was counting fingers in the left eye, and it improved to 6/24 after 5 weeks. So field of vision had central scotoma in the right eye. Color vision was defective, improved after 4 weeks. Both eyes, pupil size was 3.5 mm, irregular pupil with posterior synechiae, and festooned pupils were there. And they were non-reactive. And RAPD was present on the left eye. Fundus showed hazy media and disc hyperemic edematous with blurred margins in both right as well as left eye. She had developed a festooned pupil this time, suggestive of uveitis, anterior uveitis. And this is the fundus picture of the right eye as well as the left eye. Both showed profuse disc edema with blurring of disc margins and attenuation of vessels at the margins. And the investigation wise, VP was all prolonged in both eyes. VP was prolonged, and the field showed enlargement of the blind spot in both right eye as well as left eye. There was enlargement of the blind spot. And slit lamp showed features of anterior segment uveitis, which sediments were there. Showed anterior segment uveitis present in the both eyes, such a chronic anterior segment uveitis. And OCT was done. OCT here showed the macular edema. Here we can see the macular edema. Macular edema was there, and subretinal fluid collections were there. Here we can appreciate the subretinal fluid collections. We can see the neuroretina is detached from the rest of the retina, and we can see subretinal fluid collections were there in the both eyes, OCT of the right as well as the left eye, with macular edema with subretinal fluid collections were there. And we did a B scan of the patient, and B scan relieved. There is we can see serous exudative retinal detachment. Here we can see this is the retina layer is getting detached from the rest of the retina layer. This is exudative detachment of the retina. We can see, you can appreciate the rest of the retina, it is getting detached. You can again appreciate this. There is a gap in between the two layers. The neurosensory retina is getting detached from the rest of the retinal layer. So serous exudative retinal detachment was seen in the B scan. And FAF showed, fundus autofluorescence showed hyperfluorescence spots were present. Again, we could see started like hyperfluorescence spots were present in the eye. So out of investigation protocol, we have investigated for the last TB is the most common etiology for uveitis in India. We have we plan to do a IGRA test also. So IGRA turned out to be positive in our case, but IGRA test just says about the latency of the DB, about the latent DB, whether it is a infective or not. We can't assess with the IGRA test. It just the patient is exposed to TB and patient is having the bacteria, but whether it is causing the illness, we were not able to conclude. So here we have a patient, 26-year-old female, presented with recurrent episodes of optic neuritis, alternating in each eye, followed by last episode of bilateral optic neuritis with features of bilateral uveitis. So finally, we diagnosed this case to be a case of probable Vogt-Koyanagi-Harada syndrome. He was treated with methylprednisolone, pulse therapy, and was started on topical and oral steroids. In view of IGRA positivity, she was given empirical ATT also. So 1 month after treatment, the disc edema was still persisting, but her VP showed good improvement. VP of both P100s came to be normal to normal values. So in both eyes, VPs were normal. But the optic, the OCT, still there was optic. Disc edema was there because all 4 quadrants were still white. We can see there is a disc edema in all 4 quadrants. This is 1 month after the follow-up. On the right side, it was mildly improving, but the subretinal fluid collections were all gone. No CT, subretinal fluid collections were all subsided. In all sections, we couldn't see even a single pocket of fluid. Everything subsided, and even the we repeated the B scan after 1 month, but the exudative serous RD was completely resolved. We couldn't see any exudative RD in the repeat B scan. It got completely resolved. Completely resolved on both eyes, both right eye as well as left eye. And since leakage syndrome can have hearing loss as a clinical symptom, patient didn't have any symptoms as such, but we rolled out any hearing loss. We both right and left eye, there were no features suggestive of hearing loss. And this is the last 1 week back. She again came back for follow. So her fundus is getting again compared to the last 1 month back picture. This fundus is mildly is improving. Edema is subsiding. We can appreciate the borders. Though it is blood, it is slow. Still it's hyperemic, but still we could appreciate it. We appreciate some improvement. And her OCT was done. This OCT is done 1 week back. There's a complete improvement in OCT. There is no like all quadrants are showing green. There is no like edema as such, and there is no retinal nerve fiber thinning also. If it is thinning, it will turn out to be red or yellow or red, but there is no thinning as such happened. And this is also macula also. There is a macular edema also has been resolved. There was a macular edema before, but macular edema has got completely resolved. Thank you, sir. I invite sir for further discussion.
Thank you, Ashwin. Thank you, Ashwin. So as Dr. Ashwin has told, the first episode, since there was a central scotoma and RAPD, and we confirmed that it is the lesion is there in the optic nerve. And the second episode, similarly, patient had a central scotoma, and also there was also an RAPD on the disc. Fundus showed a hyperemic disc, and again it localized. We confirm it is it's due to the optic nerve. And third episode, similarly, patient had a RAPD was present and with a defective vision. So he has highlighted all the investigations, what are the necessary investigations, and some viewers have asked whether we have done a syphilis, and VDR was done, it was negative. And we repeated the MRI brain with optic nerve cuts. We also repeated serum MOG and aquaporin 4 during the fourth episode, and it again turned to be a negative one. And slit lamp examination showed a uveitis. So I have highlighted only one. So OCT showing a subretinal fluid collection in both eyes. So this is a fundus fluorescent angiography showing a hyperfluorescent spots. And just I'll summarize this slide. And the first option, probably we thought of a VKH syndrome. Why the points for us? There is a pan-uveitis with optic neuritis, serous exudative detachment, hyperfluorescent spots, which is diagnostic for this VKH syndrome, and there is subretinal fluid collections. And the points against this recurrent episodes of optic neuritis, which is points against that, and also the patient didn't have any extraocular manifestations. And SLE and uveitis in a young female is a points favoring SLE, and uveitis is less severe. The points against SLE is the uveitis is less severe, and ANA profile is negative. There is no other systemic signs and symptoms were there. And sarcoidosis, the points favoring sarcoidosis is uveitis with optic neuritis, and the points favoring against sarcoidosis is there is no systemic signs and no facial swelling, and there is no CT thorax is normal and AC levels were normal. And Behçet can also present with uveitis, but there was no oral ulcers and other signs. And Sjogren's can present with uveitis with optic neuritis, but there is no parotid swelling in this patient. There is no history of any dry eyes or dry mouth, and ANA profile is normal. IgG4 disease can also present uveitis, but there is no orbital inflammation or no extraocular manifestations in these patients. And coming on to TB can present with pan-uveitis and IGRA positivity, but the point which is against the TB is isolated recurrent optic neuritis is rare, and there is a thing which is against this TB. And syphilis can present uveitis, but there is no other manifestations for syphilis in these patients. And primary demyelinating diseases, and they can present with recurrent optic neuritis, which we thought in this patient, but uveitis is very unlikely in this patient. Then the two questions which arose are VKH syndrome, can it present with optic neuritis, and can it be a TB as IGRA is positive? So I came across two studies which showed what Koyanagi-Harada syndrome presenting as optic neuritis. So they have mentioned that VKH syndrome should be included in differential diagnosis of any patients with bilateral optic neuritis, even when extraocular manifestations of the diseases are absent. And another case report showing unusual neurological manifestations of VKH syndrome, and they were told that around 9.3% of patients can initially present with optic neuritis-like syndromes. So at last, we came to a final diagnosis of probable VKH syndrome presenting initially with optic neuritis. So, just I want to tell the criteria of VKH syndrome. So you have five things. First is an absence of a history of penetrating ocular trauma, absence of other ocular disease entitis, bilateral uveitis, neurological and auditory manifestations, integumentary findings not preceding onset of CNS or ocular disease such as alopecia, poliosis, and vitiligo. So when in complete VKH, the criteria 1 to 5 must be present, which is not there in our patients. And in incomplete VKH, criteria 1 to 3 plus either 4 or 5 must be present. That is also not there in this patient. So it fulfills the criteria of cases fulfill the criteria of probable VKH, isolated ocular disease, where the criteria 1 to 3 were present, which is present in our case. So the treatment for VKH syndrome is topical steroids, mainly to treat the anterior segment inflammation, and regional steroid injections to the orbital floor or posterior subtenon injections, and NSAIDs can be given, naproxen 500 mg twice a day. So other treatments of cryotherapy, we can give cryotherapy, we can try intraocular steroids, and if severe symptomatic inflammation are present, we can try with systemic steroids, and immunosuppressive agents like MF, methotrexate, and tacrolimus can be tried in patients who are resistant to steroids. And for other resistant cases, we can also try with interferon beta and infliximab. And prognosis is variable and dependent on achieving control in the early stage. So early control of the disease is very much important for a good prognosis of a patient. Thank you.
Over to Professor Ravi Kumar for concluding remarks. Meanwhile, there are a couple of questions. We will take it at the end of Professor Ravi Kumar's remarks.
It is a very interesting case of recurrent optic neuritis presented as visual loss. Whenever the patient is present with recurrent visual loss, we will primarily think of central demyelinating disorder. Whether it is a primary demyelinating disorder, but the imaging doesn't show even during the acute attack. There is no contrast enhancement of the optic nerve. Even after chronic phase, after the 1.5 years, there is no optic nerve atrophy. So all the futures are in favor of due to papillitis, the most anterior part of the optic nerve involvement. So even though initial period we investigated thoroughly to rule out primary demyelination, multiple sclerosis and NMO spectrum disorders are done, they were negative. Then since it is a female patient, all the investigations were done to rule out immunological, other SLE, other disorders, the ANA, everything is negative. So we are in a position now to able to pinpoint final diagnosis, but not complete. When the patient developed uveitis only, we are able to come to some conclusion. So we for these type of patients, we need an interdepartmental approach. So ophthalmologist opinion is very much needed for this type of patient. They can able to say what all the retinal involvement, exudative, how much areas got involved. So finally, after ruling out all the causes with the probable clinical and radiological investigation and biochemical investigation, we came to a final conclusion. It may be VKH syndrome. So even though so the treatment is even though it is for the exclusive ocular manifestation, only intraocular steroids, but complications are there. But it is a systemic involvement. It is the intolerance to the melanocyte. So it involves the choroid retinal involvement and inner ear skin manifestation, other manifestation. But other manifestations are not there to conclude it is a definite diagnosis of VKH syndrome. Most probably it can be there. But we started the patient with the ATT because of the granular metastasis possibility. Thank you for the discussion. We need this.
Thank you, Ravi. And
yes, sir.
The questions, one person anonymous attendee has is it lymphoma? No, already is being turned. What are the points against crayon? I think crayon doesn't have UVL involvement, no?
Yes.
Crayon doesn't have UVL involvement. That is the point against.
Yeah.
And one person is a vitreous biopsy with the gene expert and malignant cytology can help in ruling out TB and lymphoma. So there's a anonymous comment. Gursharan Singh, was infective cause ruled out before initiating IVS on the first and second episode? The first and second episodes were outside the hospital, no? It is not by you. No, it is outside.
Yes, sir. Yes, sir.
Yeah, so
outside.
So we don't know that
the first and second were outside, sir. We received patient, but
whether they ruled out or all, we don't know. The Dr. Lakshmi Lavanya has asked, sir, improvement in ICT and the fundus at the end of completion of ATD are no relation in this case.
Maybe the response because of the ATT. Already the patient previously treated with steroid.
each time patient improved, sir, after giving steroids. After starting ATT, 3 weeks after starting ATT, we repeated the VEP, sir. It improved, sir. So such a drastic improvement within 3 weeks of ATT is unlikely. So I would like to take this improvement with regard to starting steroids, sir. Because each episode, whenever we start steroids, patient improved drastically within 1 week, 1 to 2 weeks, patient improved, sir. So rather than ATT, it was because of the steroids, patient got some improvement.
All the previous episodes, she has responded only to steroids. So this, in view of a suspicious IGRA positivity, we have started an empirical anti, and that is, I don't think that has any effect on the improvement. It is only the steroids.
Yes.
I also feel similarly.
Yes, sir.
Okay. And is there any other question from anybody? Is there any? I think we've answered all the Gursharan Singh. We've answered. What is the plan of managing optic neuritis in PKH, which already been elaborated? So I think we have completed all the questions, and I thank all of you the entire team of KAP for a wonderful presentation. I think now it's all the residents have been very familiar with what are all the differential diagnosis for recurrent optic neuritis alone and recurrent optic neuritis with uveitis. What are the differential you have to consider, and what are the criteria, the take-home criteria of what is the definitive diagnosis of VKH, what is the probable and possible diagnosis of VKH, and what are all the criteria, all beautifully enlightened by Janu Santosh, and Dr. Ashwin, and finally concluding remarks by Professor Ravi. Thank you so much for a wonderful experience. I now hand over Professor Sudhisha, sir. Any comments, sir?
Sir has left.
Okay, no issues. Then I hand it over to the organizers for.
Yes.
Thank you. Thank you.
Thank you, sir.
Thank you so much,
Thank
sir.
you, sir. Thank you so much,
Thank
sir.
you, sir.
Thank you
As
so
we
much.
conclude episode 59 of Secrets of Neurology, we extend our heartfelt thanks to each one of you who has joined us in this evening and made this session a truly enriching learning experience. A special word of appreciation to KAP Vishwanathan Government Medical College, Trichy, for his graciously hosting today's episode and adding immense value to this academic journey. We are especially grateful to Dr. Ashwin Ji for presenting such a compelling case, to Dr. Jenu Santosh for his insightful analysis, and of course, Dr. Professor V. Ravi Kumar for his expert guidance, summarizing and discussion with exceptional clarity and depth. Thank you so much, sir. We would also like to take this opportunity to thank our visionary course directors, Dr. Sudhir V. Shah and Dr. Lakshmi Narasimhan, whose unwavering dedication continues to inspire neurologists nationwide. Their commitment to academic excellence is the driving force behind the success and growth of Secrets of Neurology. To our dedicated viewers, thank you for your continued engagement, curiosity, and support. Your energy is what makes this a journey truly meaningful. We are thrilled to share that in the upcoming episode, Secrets of Neurology will celebrate a major milestone, 5 remarkable years of continuous learning and knowledge sharing. Stay tuned as we announce the date for the airing of our 60th episode, a landmark moment in this journey. Until then, stay curious, stay connected, and have a restful night. Good night and take care. Thank you so much, sir.
Thank
Thank
you.
you.
Lakshmi
Thank
sir. Thank you, Ravi sir.
And thank you, madam.
Thank you,
Thank you.
Jenu sir.
Thank you.
Thank you,
Thank you.
Ashwin.
Thank you, madam.
Support.
Thank you.